form. So let's get started with the talk of the day. We have dental biofilm, okay, and we're calling it biofilm now and not just plaque, but it's the microbiology of the periodontium in health and disease, okay. This is a bacteria and they have a community that talks to each other. It really is quite a sophisticated community. And the more we learn about it, the more interesting it becomes. It used to just be, when I was in school, it used to just be the stuff that collected on your teeth that you had to brush off. Well, now we're learning more and more about the community and, excuse me, and what it does. So perio is really all about the bugs. And the bugs are that microscopic things that we can't see. So because of the presence of non-shedding oral surfaces, such as your teeth and restorative materials, there is a surface attachment that's present. Okay, you've got stuff in your mouth that's not moving, so things are going to collect on it, barnacles, you know, so to speak. And the term biofilm was first proposed in 1978 by Costerton, okay, and his colleagues. Now, when you get into reading literature, Costerton is one of the famous researchers. And they describe a diverse microbial community that is attached to a surface. 1978. Now that even predates me. I started dental hygiene school in 79. So our textbooks did not have the word biofilm in them, and it was still just plaque. So we're going to be discussing the role of biofilm, how it develops, what is composed in it in both health and disease, and certain methods to combat their presence, because no matter what we do, we can't get away from this biofilm. So the first thing to know is that biofilm is a microbial community. It's made up of bacteria, but not just bacteria. We used to call plaque bacteria, and we thought that's all it was just bacteria. But there's a matrix of polymers, so it's bacteria and saliva. And the bacterial cells are about 15 to 20% of the whole volume of biofilm. Yeah.
The slides are not going through. It's still on the very
No, I've got great slides.
They're very pretty. I want to see them.
Well, no, I don't. Oh, well, I'm sharing my screen.
Yeah, I don't know. I don't know much about technology except that it just still says chapter 3 on the top.
Okay, are you seeing introduction now?
No.
Oh, crud.
This might be your personal screen I see, as opposed to the...
Yeah, we see the PowerPoint like document open, but we don't see the slideshow going.
Okay, well, let me pause this recording. Okay, let's get back to the recording. So we know that you have things stationary in your mouth, and the stationary things are going to collect stuff. And that stuff is, okay, biofilm. Biofilm isn't just bacteria. It is bacteria and saliva. Now look at this. The bacterial cells only make up 15 to 20% of all of that stuff that's in the mouth. 15 to 20%. It's not a whole lot, but you've got the glycocalyx, which is a predominantly water and aqueous solutes. That makes up most of it, 75 to 80%. So you've got all of this other stuff. Then you've got your exopolysaccharides, your EPSs you're going to be seeing. Exopolysaccharides are produced by the bacteria in biofilm, and they make up 50 to 95% of the dry weight. Now, we don't have dry weight in the mouth because we have saliva, unless you are on a tube, a ventilator, which I'm learning more and more about every day with my daughter. But there are stages of biofilm development, and we've touched on this a little bit in 141, and we're going to be touching on it in 142, and you're going to be touching on it in Perio as well. So everything interrelates, and you're going to be touching on it again when you study for your boards. But the development of biofilm occurs in stages. You have the adsorption of the molecules on tooth surfaces, and then there's a conditioning film. So things stick to the tooth surface. Then you've got your reversible and irreversible adhesions. So there's a passive and active movement of the acquired pellicle. Now, who remembers what that acquired pellicle is composed of? And there's crickets. Okay, the acquired pellicle, does it occur rapidly or does it take a long time?
Almost immediately, right?
Rapidly, it's almost immediately. So we spend not all of our time, but we spend meticulous amounts of time polishing our patient's teeth, and that removes the acquired pellicle. And then within minutes, it starts forming again. But that's why the patients love having their teeth cleaned. They equate the polishing to the cleaning, even though you've just spent hours with your instruments and your scalers and everything else. And they're going, what are you going to clean my teeth? So it takes some education on our part to let the patient know that this does nothing for you except make them feel good for a little while, because tomorrow the grass is going to be fuzzy on your teeth again. So the acquired pellicle, it has those polysaccharides in them, and it's derivatives of the saliva. Okay, and they increase in biomass and exopolymers. Okay, so they just grow. Okay, they're just accumulating, and that is the biofilm matrix. So you start with the pellicle. The pellicle is sticky, so more stuff can stick to the pellicle, and it grows and it grows and it grows. So we have certain stages of adsorption of the molecules. Adsorption, it's the stickiness. Absorption is when things get incorporated into it. Adsorption is things being stuck. So absorption of the molecules, okay, it should be adsorption, I'm sorry, are mainly derived from saliva, but in the subgingival environment underneath the gum tissue, they originate from the gingival crevicular fluid. Now, remember last week we were talking about the junction gaps of the desmosomes and hemidesmosomes, and that's where that gingival crevicular fluid seeps out. You don't have a whole lot of it in health, but as disease starts, inflammation starts, the gingival crevicular fluid increases. So it's got good protective properties because that's where your neutrophils are being derived from, but it also encourages biofilm formation. So the tooth surface is altered by formation of a conditioning film to allow the interaction with bacteria. So that conditioning film is setting up the scenario, telling the bacteria, I am a safe place for you to come. So let's have a party. Then there's this reversible and irreversible adhesions, and it's passive active movement with the acquired pellicle. So after the development of that conditioning film, you have reversible adhesions that occur between the charge on the microbial cell surface and the charge present on the conditioning film. Now, you don't need to know this, okay? But remember, you've got pluses and minuses, right? And opposites attract. And that's all that is saying, is that it's setting up the environment. So there's a reversible situation where the microbes collect on the conditioning film, so they stick to the conditioning film, either passively through the salivary or gingival crevicular fluid, or in a few cases by their own transport. So that conditioning film alerts the bacteria, yoo-hoo, come on over here, party underneath the gum tissues here. But some of that bacteria can get there on its own. Those are the party crashers. we have irreversible situations going on, and that develops through the interaction of adhesions on the microbial surface, and there's receptors present in that conditioning film, right? Again, we're talking pluses and minuses. These adhesions provide a strong bond for the biofilm formation. And it's during this time, both secondary and late colonizers adhere to the receptors on bacteria that are already attached to the acquired pellicle. And that leads to microbial diversity within the developing dental biofilm. So you're starting with that conditioning film that's on the tooth, your acquired pellicle that is sending signals to the bacteria with the pluses and the minuses, and there's signals that we're going to be talking about to attract the bacteria to it. And it's not just one type of bacteria, it likes diversity. It likes diversity.
I have a quick question. So the difference between reversible and irreversible is that irreversible contains receptors, and that's what makes it irreversible?
Yes.
Okay. Thank you.
Yes. And I don't know of any board question that has asked that type of question. Well, let's just say that minute piece of information. They're more interested in the type of bugs and microbes dealing with perio, and that's what I'm going to be concentrating on. I can guarantee you I'm not going to be asking you that question. So we're increasing in mass. Things are undisturbed. So we've got an increase in biomass and synthesis of exopolymers, and that equals the biofilm matrix. So the biofilm contributes to the structural integrity and resistance to environmental factors and antimicrobial agents. So swishing with an antimicrobial agent really doesn't do a whole lot of good in a subgingival biofilm formation. They've got these exopolymers. They have things to protect them. So the biofilm matrix can be biologically active and retain water, nutrients, enzymes. Okay, so it's got their community so it can thrive, but it can also restrict the penetration of certain molecules, right? And that's one reason why, again, the antibiotics, even systemic antibiotics, don't really work well with trying to treat periodontal disease oftentimes, because they can't make it into that biofilm matrix. It's a smart system. So in response to these gradient changes, the small changes, the microorganisms alter their pattern of gene expression to result in a heterogeneous environment. So the bacteria is changing so it can thrive. And it's changing, it's embracing the diversity of the different bacteria, and it's becoming stronger. So that's the reason why microorganisms with contradictory growth requirements coexist within biofilm. So you have your anaerobic bacteria, your aerobic bacteria, your gram positive, your gram negative. You've got all of this stuff that's going on, and it's surviving quite well and thriving quite well. One of the many, many examples of what you can find for stages of biofilm development. You have your protein adsorption. So this is your tooth surface. Then you've got your protein adsorption. So you've got your conditioning film. Then you've got, okay, planktonic bacteria starting to stick to it. It is not disturbed. Okay, so you've got more bacteria, and you've got bacteria that is detaching the growth and metabolism by adherent bacteria. Some of this stuff detaches. And this is where the science is coming in with that oral systemic link. They're finding bacteria that originates in the mouth in other parts of the body. So they are associating, stroke, heart disease, even Alzheimer now is being linked to bacteria that originates in the mouth, that detaches and floats around. So depending on what book or article you're reading, over 700 bacterial species reside within the oral cavity. 700 is a very conservative number. Every time I pick up a new article, the number is increasing. The last one I read was saying 900 to 1,000. So, 700, very conservative. You've got a bunch of different bacteria that can be in your mouth. Now, not everybody's going to have 700 different species in their mouth, okay, but there are different species. Periodontal disease appears to follow the microbial shift hypothesis. Oh my gosh, what's that? We're going to get into that. But the microbial shift hypothesis, there's different theories on how periodontal disease develops. And that is the one that seems to be in favor. Okay, it's been around a while. Now, the study by Lowe and his colleagues, Lowe is a very famous researcher, and it's supposed to have 2 dots up here, but I don't know how to make it on my computer. But Lowe, okay, 12 subjects. Now, is that a large pool of subjects or a small one? It's a small one, 12 subjects. Okay, these were dental students, and we've talked about this before, that ceased oral hygiene to be monitored clinically and microbiologically. So this is where the Shillness and Lowe, all of this research came in with 1 to 2 days, 2 to 4 days, 6 to 10 days, and then 10 to 21 days. Yes, you need to know this. You will be visiting this again when you're doing your board review. 1 to 2 days, sparse flora in a dense gram-positive cocci and short rods. All right, so it's gram-positive and it's aerobic. 1 to 2 days, sparse, it's just forming. 2 to 4 days, you've got filaments that start to form and your rods increase, with cocci still in large numbers. It's just growing. Then 6 to 10 days, you've got a gradual shift to the vibrios and spirochetes. Okay, and spirochetes, if you're seeing spirochetes on a microscope slide, you know that's mature biofilm. 6 to 10 days, gradual shift to vibrios and spirochetes, and it's still, though, 45 to 60% gram positive. Now that's important: gram positive, gram negative, aerobic, anaerobic. Okay, those are terms you're going to need to be associating with health and disease. The appearance of clinical gingivitis is related to gram negative forms of bacteria. So when the bacteria first starts forming, we are gram positive. Gram negative starts those harmful effects. Days 10 to 21, gingivitis begins. So these were a group of dental students that didn't brush their teeth. And he took bacterial samples every day. You need to know the term dysbiosis. That is, in other words, the microbial shift hypothesis. But dysbiosis came out a few years ago, and you're going to hear about it in every periodontal continuing education course you take from now until there's another theory that comes out. Dysbiosis, which means some of the diseases are due to a decrease in the number of beneficial bacteria or in an increase in the number of the bad guys. So as this biofilm mass changes from health to disease, there is a whole shift from healthy bacteria to the bad bacteria. So it's the transition of health to disease. So you predominantly, when this biofilm mass starts forming, it's predominantly gram-positive and aerobic. Okay, it utilizes air to survive, and they're gram-positive. Now, the difference between gram-positive and gram-negative is one of those terms, whether it stains purple or not. Okay, but gram-positive aerobic bacteria is healthy biofilm. Dysbiosis is when it changes, it transitions into that gram-negative anaerobic bacteria. Gram-negative is associated with disease. Anaerobes are associated with disease. So gram-positive is health, aerobic is health, gram-negative disease, anaerobe is disease. Gingivitis is reversible and it can be resolved in a week when care is shown. All you need to do is be disrupting that biofilm and things will be reversed. Gingivitis is a form of gum disease, but it's the only of periodontal disease, but it's the only reversible stage of periodontal disease. More researchers. Sokransky, again, a very big researcher. Sokransky described microbial complexes in a color scheme. So the initial colonization, they put in as yellow, green, and purple. Green, okay, think about a stoplight. Green, yellow, not as good as the green, and purple. It progresses to orange and red. Red means stop. Red is bad. So orange and red complexes are comprised of species thought to be the major etiologic agents of periodontal disease. So they have these charts, and you're going to be seeing all sorts of different charts also, which we'll be getting into. But this is showing you the different colors of the bacteria. All right, so we're coming up also with, we've got the biofilm, we have just a few things sticking, okay, to the tooth surface. Then we've got the gingival crevice, and look at this, you've got a filament starting here, but you've got green, you've got purple, you've got all sorts of different colors going in. And look over here on the periodontitis side of things. More of these filaments, okay, more bugs. Look at also the bacteria that's associated with caries or cavities, demineralization. It's a different bacteria that's associated with periodontitis. Different bacteria. Some patients might not even have the caries type of bacteria in their mouth. Who determines, or what determines what type of bacteria takes up in our mouth? Do you remember? Usually it's the primary caregiver, because when a baby is born, they don't have bacteria in their mouth. But we kiss, we coo, we blow raspberries. You know, we do all of that. We're testing the baby food with our mouth, and whenever our saliva gets incorporated into that infant's mouth, our bacteria sets up residence into the baby's mouth. So the healthier the parent or that primary caregiver is, as far as oral hygiene, what's going on in the mouth, the healthier that bacteria is going to be that's setting up residence in that child. So this is one of the classic color schemes. Are red the good guys or the bad guys?
The bad one.
The bad guys. All right, subgingival microbial complex. These are the good guys over here. You've got your green, your yellow, okay, and your purple. Then we've got our orange complex, which is kind of a combination. It's going into the bad guys, and the real bad guys are P. gingivalis, B. forsythis, and T. denticola, the real bad guys. Those are your red complex. And what we're going to be discussing is the shift for everything. But look at all the bacteria that's present. You know, lots of different bugs in there. Do you need to know all of them? Absolutely not. But you need to know the major players. And that's what we're going to be getting into in this course. We're going to be talking about the major players. This is just another form of it. 1998. The bacteria is the same, it's just looking different, it's more colorful. Again, the red complex, we are going to be talking about red complex. And again, another scheme. This all came from Sokransky's research. Early colonizers, middle colonizers, late colonizers. Look at where the red is. Okay, P. gingivalis, T. forsythis, and T. denticola. Up here, the red colonizers.
So the ones in red are the anaerobic ones, right?
Yeah, they're the bad guys.
Okay. And they're last because they need that thick biofilm to create that anaerobic environment.
Yes, they need to know that it is a safe place for them and that it will not be disturbed and it can thrive.
Okay, thank you.
This bacteria is very smart.
Is that primarily subgingivally?
Yes. Absolutely. Okay. Now, again, this is something that you've had in 141, the phases of biofilm formation. See, you're never going to get around this. Begins from days 1 to 2. Okay, so we're still talking about that low, you know, those dental students that didn't brush for 2 weeks. As soon as it's exposed to saliva, okay, biofilm formation can form. It extends laterally and perpendicularly to form parallel layers of bacteria. They are gram-positive, coxy with some short rods. Strep mutans and strep sanguis. Strep mutans, what are the mutans known for? Caries, cavity causing, strep mutans. Actinomyces has the ability to adhere to the surface and co-aggregate with other bacteria. So you've got these actinomyces that are saying, come, let's party. Yeah, we're a little bit different, but that's okay. Does this look familiar to you guys? So you've got the initial thin continuous band at the gingival margin. Okay, the bacteria is starting to collect, and then it forms layers. Two to 4 days is considered phase 2. You have early plaque mass that's provided at the base next to the colonies. You've got your gram-positive rods and gram-negative coxy form. Okay, so you've got a couple little gram-negatives starting to get in there. But it's the formation of an anaerobic environment. Okay, just in days 2 to 4. So you have your anaerobic and facultative anaerobic bacteria. Facultative anaerobic bacteria are things that can survive in air or not with no air. It's just kind of, it doesn't care with or without oxygen. It'll take it. AC/DC. It hasn't decided what it wants to be. So we're still talking phase 2, 2 to 4 days. Coxy still dominate the biofilm or the plaque mass. You've got filamentous forms and slender rods starting to compete for the space. So you've got these other bad guys coming in, and those are your rods and your filaments, okay, long skinny things that are trying to take up residence. So it's pushing the other bacteria out. And a matrix begins to form around these bacterial colonies. All right, it's making condominiums, okay? It's the matrix is the cement around the bacteria. The bacteria can form extracellular polysaccharides, which are carbohydrates derived from sucrose. Now, when I say that, it doesn't mean that if you don't eat sugar or any carbohydrates, you're not going to have this happen. This comes from your gingival crevicular fluid and your saliva, so this is going to form whether you're eating anything or not. But these polysaccharides aids in the adhesion and insolubility that increases plaque resistance to removal. It's forming a barrier. Then you've got these levans and soluble glucans that are the energy source for the bacteria. So it's got its own battery in there feeding the bacteria. It's creating a film around it to make it insoluble and to make it more sticky, and it is creating its own food source. So phase 2 is getting a little bit thicker. Phase 1, you were having these outshoots here, but in phase 2, you've got your gram-positive rods as well as some gram-negative species. You've got anaerobic bacteria starting to infiltrate this bacterial mass. Things are left undisturbed for 4 to 7 days. That takes you into phase 3. So you have more filamentous bacteria. You've got rods, filaments, and fusobacteria that co-mingle as non-motile bacteria and move with the motile bacteria, because bacteria is living. So it's going to move. The question is, does it move fast or does it move slow? So you've got your Vibrios and your spirochetes that begin to colonize. Spirochetes, bad. You have new plaque, which are your cocci, may lie on the surface of mature plaque or spread coronally at the margin. So you're always having new biofilm formation. And it's called the corn cob formation. So if you've got calculus on your tooth, that calculus is always going to have biofilm on it, always. It's rough, it's porous, even though it's hard, and bacteria is going to get on it. So we're still talking phase 3 as the days go longer. The plaque continues to mature. So you're having more of those Vibrios and spirochetes continue to multiply. New species, Vibrios, are starting to come in. You have a host response, which is the early signs of inflammation and observable gingivitis. Phase 3, observable gingivitis. It's part of the periodontal disease process. It's the only reversible stage. But look at the difference between, okay, you've just got the little layer here versus what's going on in 7 to 13 days at the bottom. That's a lot more bacteria. And look at what the picture's showing from the gum tissue. It's starting on top of the gum at the gingival margin, and then it starts cascading below the gum line area. So when we're doing oral hygiene instruction for our patients, it's really important when we're using our disclosing solution and talking about, you know, you want to angle the brush at a 45-degree angle. They don't know 45 to anything, but what happens on top of the gum has a direct effect with what's going on underneath the gum tissue. So we have to maintain a healthy environment on top of the gum line area, coronal to that. So it's going underneath the gum tissue. Days 14 to 21, you've got your vibrios and spirochetes. They're anaerobic. You've got growth accumulation and pathogenicity of subgingival plaque, okay, that are strongly influenced by supragingival plaque. What happens on top of the gum, supragingival, has a direct effect on what's going on underneath the gum tissue, because what's happening on top grows and it develops subgingivally. You have days 14 to 21, more anaerobic, more gram-negative, and more motile organisms. They're jumping around. You have swelling or edema that causes gingival enlargement, which is gingivitis. It alters the gingival margin for easier access to the root surface. That swelling of that gingival margin makes it more friable. It makes it more flappy. So bacteria has an easier entrance subgingivally. Many motile organisms that are completely unattached to the plaque are also going underneath the gum tissue. These bacteria produce toxins and enzymes that cause direct injury to the periodontium. And that's the critical reason to remove the subgingival plaque. Okay, that's why we're angling the brushes like we're angling to try and get underneath the gum tissue into that gingival crevice. The new classification of AAP, which came out a couple years ago, has implant categories. So you have peri-implant mucositis and peri-implantitis. You do need to know this. Peri-implant mucositis is an inflammatory lesion that resides in the mucosa. So think of peri-implant mucositis as gingivitis around an implant, versus peri-implantitis affects the bone. That's periodontal disease. That's apical migration. You don't have a junctional epithelium, but the bone is starting to be affected. It's the formation of a biofilm that's similar to dental implants and on the teeth, but that microbiota is associated with peri-implant, and it's dominated by a diverse gram-negative anaerobic bacteria. It is predominantly red complex, the bad guys. Peri-implant mucositis is gingivitis. Peri-implantitis is bone destruction. So there's really no evidence right now for the existence of one or a group of specific bacteria that's responsible for peri-implant disease. They're thinking it's the same bugs that create gingivitis and periodontitis in a natural toothed environment. But there's a possibility that the peri-implant and chronic periodontitis microbiota may be different. We don't know yet. They're still doing research. The implants and the success of implants when they were first being studied was in Europe, and these mouths were edentulous. They had no teeth in, and they were being restored with just implants. Well, now we have natural teeth and sitting right next to an implant. So they're really looking at, is the bacteria different for those of us that might have both things going on in our mouth? We don't know yet. But the disruption of oral biofilm is the gold standard, our gold standard. Get the biofilm off the teeth, you'll be healthy. For treating periodontitis, it's scaling and root planing or debridement. And when the expected outcome, okay, and what we're looking for is resolved inflammation and decreased probing depths does not occur, the clinician should consider alternative modalities, and one of those is antimicrobials. Now, earlier I stated that the bacteria is fairly resistant to mouth rinses and those type of things. So we are going to be delving into more of this. We've got chapters on it. But first we have to remove the calculus to the best of our ability. Do we ever remove it all? Heavens no. Heavens no. So we want to be looking at the microbiota that's going on underneath the gum tissue and what can we do? Antimicrobials are either given systemically, you're swallowing a pill, or applied locally within the periodontal pocket, or we are putting it into the pocket. Antimicrobials are only effective when the biofilm is disrupted. So before we even place an antimicrobial subgingivally, we got to get all that biofilm out of there. Otherwise, it's like it's wearing clothes and you're trying to take a shower. Is your skin going to become clean if you still have your clothes on? So because biofilm itself offers protection of the drug-sensitive microorganisms, you want to remove as much of the biofilm as possible, because many instances the biofilm bacteria are up to 1,000 times more resistant to antimicrobial agents than just planktonic bacteria. This bacteria is smart. It protects itself. It wants to live. It wants to thrive. It wants to eat. So it becomes resistant to antimicrobials. So periodontal disease really has multiple risk factors. Okay, we know about some of these risk factors. If you smoke, if you're diabetic, we're going to be getting into more of that. But biofilm is the primary etiological factor. But you can also have local and systemic factors that play an important role. And we discussed blood pressure, diabetes. Why would diabetes be a factor? Diabetes alters your immune response, so you don't have wound healing as adequately as if you didn't have diabetes, because it alters the neutrophil. And your neutrophils are the first line of defense. Those white blood cells, they don't last very long. They only last for a very short time, but they come through the gingival crevicular fluid to fight disease. That's your first line of defense. And if you don't have your body making them in adequate amounts or in a healthy form, you're not going to have that first line of defense. And we'll be discussing more of that oral systemic link. So it's important that the patient be aware who's at an increased risk, especially when treatment is unsuccessful. You have a smoker in the chair, you know they are not going to respond as well as a non-smoker. You just know it. So some periodontists won't even surgically treat a patient that's still smoking. So there's something called the parameters of care. Hopefully that sounds a little familiar to you. The parameters of care that suggest that the initial therapy of patients with inflammation should include the elimination, alteration, or control of risk factors that may contribute to chronic periodontitis. So they're linking smoking with chronic periodontitis. I got control over that. Supposedly, you stop smoking. Obesity is now being linked to chronic periodontitis. Get your weight under control. We're not going there. Get your blood pressure under control. Any autoimmune process that's going on, stress even has been linked to periodontal disease. So we want to be looking at, again, the whole person. We're not just looking at their mouth. And the parameters of care is, it's actually a book, but it lets offices know you can treat this in a general office or you should refer to a specialist. And the parameters of care, when it suggests that you refer, it's more from the litigation standpoint as well, to protect that general office from not getting sued, because dentists can get sued for trying to do things that are unsuccessful that a specialist should have. So let's have a question here. What refers to the concept that diseases are due to a decrease in the number of beneficial bacteria and an increase in the number of pathogens? Do you remember the word?
Dysbiosis.
Dysbiosis, yes. So make a note if you don't know these, because this is really highlighting what you need to know. Dental biofilm are the only etiologic factor in periodontal disease. True or false? Periodontal diseases have multiple risk factors. You love these two-part questions. The good news is the boards are using less and less of these two-part questions.
Would it be C?
Good job. All right, and that's on page 4748. Biofilm is the primary etiological factor. That plaque in the mouth when we're using disclosing solution. Can't emphasize that enough for our patients. According to the parameters of care, the initial therapy of patients with periodontal inflammation should not include
Formation.
Yeah. Microbiota of subgingival plaque is generally more anaerobic, more gram-positive, and more motile. Now it's talking subgingival. There are many motile organisms that are completely unattached to the plaque matrix.
The first one is definitely false. I want to say the second one might be true. Let's see.
There you go. So even if you don't know, you can kind of rationalize what you do know and try and apply it to a question. I'm having a speaker come in. The Northern Virginia Dental Hygienist component is working with one of my former instructors who does board reviews. Her name's Nancy Cherner, and she's going to be having a webinar with you to how do you look at these questions to answer them. You don't need to know the answer all the time. Okay, and it's really interesting stuff. Supragingival adsorbed molecules are mainly derived from what? And in subgingival environment, they originate from what? So for this subgingivally, okay, we know we're looking for the gingival crevicular fluid as one of them. Okay, that, my friends, are is the main information on chapter 3. Are there any questions? Great. Let's take a 5-minute break and I'll see if I can pull up the correct chapter 4.